week we are moving away from obesity and talking about metabolic syndrome, which isn't really moving away from obesity, but a little bit away from the social philosophical stuff I was having you investigate and provide your kind of view and your stance in the media and within society. And now we're looking at some of the science behind metabolic syndrome, which is linked to obesity. And so for the next few weeks, we're going to look at different pathologies and how exercise interacts with them. So this week is solely just metabolic syndrome. We're going to move into diabetes from here. But metabolic syndrome is an important thing to make sure we all understand. I want you to understand what the syndrome consists of, why we call it a syndrome, what our role is. So when you think about metabolic syndrome, it's a collection of interrelated metabolite risk factors that are present in a given client, individual, patient that produces high probability when you combine them together of future heart disease. So we begin screening people, and those that have these interrelated risk factors are now at a very high risk for the heart disease. We see presence among metabolic syndrome among those that are overweight and obese with other factors, and that's what I want to get into. So for some of you, this is a repeat and you're well aware of it. I know that there are a few of you already in my cardiac rehab class, and many of the classes I teach are all interrelated themselves because I'm a clinical exercise physiologist. I am not surprised that you are going to sit here saying, my gosh, I've already heard you talk about this. But just because you've heard it once doesn't mean you're an expert, and I want to make sure that everyone with all different backgrounds that we have in our class are really, whether you're going into performance and human performance and strength and conditioning and coaching, or you're heading down the clinical route, we want to be watching for clients that could have metabolic syndrome, and I'm going to go over why. So before I go into metabolic syndrome in this class, I want to just bring your attention to this table. It is right out of the small ACSM guidelines book. This is a really important table because it very concisely lists the risk factors here on the left, and then it has, in the small little font, it has all how we defined them. And this is usually where students don't know how to define them. You might say, oh, I know family history, and I know smoking, and I know being sedentary, but how do you actually define that risk factor? So I'd like you on the slides to pause, and I want you to read this and see if you actually, on a test, if you can actually give me the definition for each of these risk factors. So those are what we call risk factors. Now, when we take a look at risk factors, they all put us at risk for developing future issues, disease, mainly heart disease, cardiovascular disease. In this lecture, I want to look at certain risk factors, certain ones, not directly from this table, they're going to be different, but I want you to be aware of these risk factors. But for metabolic syndrome, now I want us to focus on this specific criteria. You will notice if you compare the two tables, the numbers are a little varying. So for metabolic syndrome, we are looking at number one for everyone is going to be abdominal obesity. So there's three defining criteria. You have to have any of the three, but the first one people need to have is the waist circumference. So men greater than 40 inches or 102 centimeters, and women greater than 35 inches, which is 88 centimeters. So number one, that's their first. Then with that, what other risk factor would put you in the category of having this syndrome? And it would be one, impaired glucose. Impaired glucose tolerance test, it's a fasting blood test with the glucose result 100 or greater. Triglycerides that are 150 or greater or on medicine. Low HDL, which is very bad, right? This HDLs are good cholesterol, and when you don't have enough of it, you're at risk. So we define low, bad, good cholesterol for men, less than 40, for women less than 50 or on medication. And then blood pressure, and if you notice, these blood pressure numbers are different. So you know hypertension is 140 over 90, right? That's one number you know. You know good blood pressure needs to be 140 or 80 or below, right? So good is 120 over 80 or below. Bad is 140 over 90 or above. And now I've got a new number on here, 130 over 85. This is the threshold we that would be evident with metabolic syndrome. So 3 of these, one being waste, so 2 others, is how we define metabolic syndrome. The scope of metabolic syndrome is that researchers state 35% of our information from the NHANES data, right, this national health data that gives us all the criteria, do not indicate a tapering, a slowing down of metabolic syndrome, right? We're not noticing that even though now we've identified it and nurses and physicians and healthcare providers across the nation are screening for metabolic syndrome, it's not decreasing. So our data is indicating that approximately 2/3 of adolescents now have one or more of these abnormalities. This is not good, right? It's now beginning to affect younger and younger people. And the cumulative cost is outrageous, right? So we know how to prevent this. We know that these risk factors are preventable. Data is showing us that we need to be screening for it, but our numbers for metabolic syndrome are increasing. So the etiology is really widely debated. Is the etiology based on, number one, that increasing weight and adipose? Is it coming from glucose problems, which is insulin resistance? Is it from the mitochondrial dysfunction that's leading to some of the other problems? The etiology is conflicting, but bottom line, what I noticed just as a clinician is that the more sedentary someone is and the more they weigh, the higher the risk of glucose, blood pressure, triglycerides, HDL, all falling into play where the numbers come out to be having metabolic syndrome. So obesity is something we've spent a lot of time on, and this is something I'm really just so passionate about sharing with you, that it's we really need to get people at a weight that they can maintain that's as healthy as possible. So it is an independent risk factor for insulin resistance. We know that as we have more fat cells, more adipose, our insulin resistance is going to go up. Hyperglycemia, hypercholesterolemia, right, which is the lipids, and hypertension. So abnormal fat distribution needs to be considered. So when you're looking at where the fat is held, and that's the android versus the gynoid, that is the apple versus the pear. We also want to take a look at visceral adipose tissue, right? So with visceral adipose tissue, right, this is fat we predominantly see in our abdomen, which we know is the android regional fat deposit, or tummy fat, where it has a really big influence on metabolic, endocrine, immune interaction. So visceral adipose tissue will increase risk for metabolic and cardiovascular disease. It will do that. Now, when and how many years? It's debatable. It looks at all the other risk factors in genetics. When we take a look at IMAT, which is intramuscular adipose tissue, independently this contributes to impaired glucose metabolism and decreased insulin sensitivity. So what I'm telling you in this slide is that obesity, if left untreated, precipitates the increase for chronic disease and all-cause mortality. There's no sugarcoating this. Do I want you to be able to appreciate people at all sizes and help cultivate a community of understanding and empathy? Yes. But I also want you to know from the scientific side that if we continue to leave this untreated, the increased risk for chronic diseases and all-cause mortality will continue to skyrocket. Insulin resistance. So, insulin resistance is considered a pre-morbid condition. The body is unable to maintain glucose homeostasis. Gradually over time, we see a decrease of metabolite health, insulin resistance, eventually leading to obese bodies. So it's important to identify these metabolic syndrome as a pre-morbid condition and treat at-risk individuals before the emergence of these categorical insulin resistance or hypoglycemia. It's really exceedingly very important. This is a very kind of directive stance that I'm giving you, but I really want you as exercise professionals to understand that metabolic syndrome is kind of this constellation term for these risk factors that increase the risk of heart disease. At the bottom line, we're really looking at adipose. We're really looking at the danger that adipose cells play on the body. We know this from the prevalence of metabolic syndrome. really within the United States, it's just continued. And we see it among race and ethnicity. There's lots of studies that look at where we're seeing more of this prevalence. But really, it is people that are obese, we're seeing it higher than those that are just overweight or ideal. When you look at kind of mitochondrial dysfunction that's causing this, right? Reduced mitochondrial size, density, function, have an etiology of insulin resistance, metabolic syndrome. We see this in diabetes. Risk of diabetes among sedentary and insulin-resistant individuals who have smaller and fewer mitochondria with impaired function. Very, very classic to see that as well. Decreased mitochondrial density that leads to complete lipid oxidation, accumulation of lipid metabolites, impaired insulin signaling, metabolic inflexibility, and oxidative stress are all really important things that we need to be recognizing, right? So kind of that cellular level of what's going on. So as we diminish the ATP, the endosin triphosphate production, energy deficient, decrease functional capacity. However, on the flip side, we see improvements with exercise ATP synthesis independent of weight loss. So just getting someone moving, even if they're not getting weight loss, guys, this is important for all of you to understand. We see improvements independent without weight loss that are really beneficial. And that is something that I really want you to understand, that the research has really showed us that metabolic syndrome with the risk factor, really visceral adiposity is an important one, and activity level is another really important thing to be aware of. So when we take a look at screening for atherosclerotic cardiovascular disease and we screen for diabetes, right? So we're looking at age, physical inactivity, obesity, insulin resistance, oxidative stress, chronic inflammation. What is happening when we call this metabolic syndrome, right? So all of those other things are going to happen, but what we see is abdominal obesity, high fasting blood sugar, low HDL, high blood pressure, high triglycerides. Now we have what we call metabolic syndrome, right? So the association between hypertension, hypoglycemia, and hyperuricemia is, right, that's elevated uric acid level in the blood. A normal limit of uric acid in the blood would be about 6.8. Anything over 7 is considered saturated and the symptoms begin occurring, right? That's elevated uric acid level. The elevated levels result of increased production and a decreased excretion of uric acid, and a combination of these both processes together. So what you want to realize is the accumulation and the clustering of obesity-related metabolite risk factors is what gives us what we know as metabolic syndrome. So signs and symptoms patients often present with is elevated glucose, hypertension, triglycerides, low HDL, which is the good stuff, abdominal obesity, what I'm talking about in the last slide with uric acid, right, microalbuminuria, kidney leaks into the albumin leaks into the urine, and this is really, right, that not safe. Elevated uric acid in the blood. We know this also, we see it a lot with obesity among fatty liver disease. What they're going to present with to you is really the elevated abdominal obesity. The rest is either going to be no symptoms or only be able to tell if we screen and do a blood draw. You understood what I just said, right? That's looking at somebody, looking at their abdominal waist size, right? Men 40, women 35 inches, because all of these others, they may not be symptomatic right away. And then as the years progress, the risk for atherosclerotic cardiovascular disease is going to increase. So that is really an important thing. We're looking at platelet accumulation, so that kind of sticky fibrin-like platelet accumulation, blood coagulation, this C-reactive protein, which is another increasing risk factor for cardiovascular disease, cholesterol that's accumulated in gallstones. We see women with hormonal issues with polycystic ovarian syndrome, menstruation patterns, unwanted hair, changing in skin tones. Sleep apnea is another really big clinical consideration. So we want to identify the core risk components for metabolic syndrome. We want to monitor actual abdominal obesity, and you really want to do a waist circumference measurement to see that. So identifying the 5 risk components of metabolic syndrome, again, it is going to involve some laboratory testing, right? Especially to look at the glucose, right? So what is going on with glucose tolerance, and what is going on with just your fasting glucose levels? Additional testing may be warranted for all of these other things I'm throwing out at you, right? So looking at clot development and fibrin and thrombosis that could be happening, looking at the blood, looking at urea, looking at gallstones, looking at cholesterol levels, just so much overall clinical inflammation. With exercise testing, we want to be looking at stratifying patients with metabolic syndrome based on numbers, right? So dyslipidemia, their cholesterol numbers; hypertension, their blood pressure numbers; hyperglycemia, their glucose numbers. Simply using a standard treadmill protocol, small workloads, taking a look at how well the body reacts to stress, reacts to exercise. Interventions to promote weight loss, as much as you may not want to hear it, it is what works, right? Can we lose even a little bit of weight? Caloric restriction, increased physical activity. We may be relying on some pharmacological weight loss medicine that are on the market for appetite suppression. With all of this stuff I'm talking about on this page, we really need to be consulting the right type of physician, right? So I'm giving you a link here of who are the physicians that are truly trained in obesity, and believe me, it's not all of them. It's few of them. I will say the same thing for personal trainers. They're not really trained for dealing with obesity. So take a look at this link and taking a look at what is the quality of a physician that really we should be referring our obese clients to. Behavioral modification. So much of what I do as a clinician in a bariatric center is a combination of myself, the psychologist, the two of us work hand in hand a lot. I'm in on the appointments. We do what we call a tandem appointment with the psych visit and the exercise physiologist. We also do tandem appointments myself, us, the clinical exercise physiologist, and the registered dietitian. So it depends on the patient's need, their understanding on where we want to hone in, but kind of tag teaming together, we really do produce behavioral modifications that seem to give us a more tangible output for the patient and understanding how they're going to make behavior changes, how they're going to quit smoking, how they're going to exercise when they hate exercising or they hate meal planning or whatever their issue may be. So with the exercise prescription with metabolic disease, we're really honing in on aerobic cardiovascular exercise. We're looking at accumulating 150 to 30 minutes of moderate physical activity or equivalent to at least 1,200 calories or more. Performing continuous exercise if they can. If they're really out of shape, I want you to use intermittent exercise if they're out of shape, right? Sessions should begin to get them at least to 30 minutes. If they're really out of shape, we're starting again intermittently, so that might be 3 bouts of 10 minutes. So 3 walks a day. If they're really deconditioned, slowly increasing to what we call continuous, get them to 30 minutes and then titrate up to 60 minutes. We really need a lot of minutes to really hone in on the fat stores. Gradual progression, so start slow, do a couple of bouts throughout the day, and then eventually we're getting it to continuous exercise. Hands down, this works. I've done it for years and years with morbid obese people, 300, 400, 500 pounds, small doses intermittently throughout the day, so they can do this 5, 6, 7 days a week. We're not trying to do a high intensity 2 days a week. That's not what these people need. In time, after they drop weight, we can start doing high intense stuff that's going to kick their butt and keep them maybe not being able to get up the next day and exercise, but that's not what we want when we're beginning an exercise program at trying to focus on weight loss. With resistance, we don't have any specifics when we're looking at overweight and obese with a metabolic syndrome, right? Ideally, minimum 2 days, 3 days a week, doing what single sets, 5 to 10 reps, titrating up the weight, using different modes from free weights, from bands, dumbbells, actual machines. Range of motion is an important thing. Too many people are not focusing on the range of motion. I also like to really focus in on the neuromuscular, right? Balance and coordination is an important one. So range of motion is really that modality to help offset the cardio and the weight training Range of motion as much as we can, minimum 2 to 3 days. We're looking at static, dynamic, or PNF. Hopefully you're all familiar with some of the basic modalities of flexibility and range of motion. Really important. Again, this is really going to be beneficial for balance. I like this table. I know on your computer it's the font is too small. You can take a look at the slides. You can take a look at it on Brightspace. But this is kind of a nutshell. It kind of summarizes everything I've said for how do you get the baseline mode? What are the protocol you're using for gathering information? What are some of the clinical measurements that we want to look at? What are the clinical implications? What are the special considerations you need to be aware of? That is really an important thing when we think about any of the topics we're going to cover in this class. These special considerations are really important, right? So special considerations of looking at treadmill protocols versus bike protocols. What are the difference? Is the obesity level, their knees, are they able to be weight bearing or not? Many people with diabetes, so a lot of these metabolic syndrome, if they have diabetes, are going to have severe peripheral neuropathy, so they are going to have numbness in their feet, would also may be more comfortable in a cycle ergometer, which you know that is a bike. If the individual is really obese and they're going to have reduced range of motion because of the excess fat, right? Don't get them on the floor stretching. Try to figure out some chair exercises or stuff they can do in the bed, with a towel and their arms and their legs. So we've got to be really creative with how we create a program that understands the clinical implications of abnormal blood lipid levels that can also have some good exercise considerations. So patients with metabolic syndrome are usually overweight or obese, like I mentioned, the waist, along with these other risk factors. Our job is to screen these people before they have full-blown heart disease. So the purpose of metabolic syndrome is trying to capture who is at risk for future problems down the road. So when you think about, well, what is this? Why are we learning about this? Right? You're learning about this because as we understand the danger of these cardiometabolic risk factors, can we make a change before the disease sets in? So diagnosis of metabolic syndrome requires presence of 3 or more of the following, and our goal is to screen these people early now at your age, right? Make changes so we don't end up in 10, 15 years having angina and a heart attack. When we combine diet interventions, exercise, it is how we can ideally maintain weight. So weight maintenance is my number one goal because people are gaining between 2 to 10 pounds per year. 2 to 10 pounds per year. Look at how much you weigh now and look at how much you weighed when you left high school. How different is that? So whatever year you graduated high school and what you weigh now, what has your average weight gain been? So if we can at least do weight maintenance, maintain and no longer gain, you're going to help lower the risk for these risk factors, right? So these risk factors of hypercholesterolemia, hypertension, so weight maintenance, if not weight loss. So we really want every one of us, every healthcare provider to be screening for metabolic syndrome. So this week I've given you a few additional readings. I've got a little bit of work for you to do to answer, and I want us to really take a look at the case study I gave you and be able to explain to me how an exercise program is going to treat somebody with metabolic syndrome, how it's going to help normalize blood pressure, right? So do you understand some of the pathophysiology behind this? Do you understand what happens when we get increased blood flow, you get the skeletal muscles moving, what the skeletal muscles are doing to insulin sensitivity and glucose uptake, what's going on with the HDL levels with improved insulin sensitivity. So really understanding moving, even if it's not as much exercise as you can do, right? Even if it's intermittent 2 or 3 intermittent bouts of 10, 15, 20 minutes a day, it's not your continuous, 45, 60 minutes. Can you articulate this in the assignment this week?